Well, I'm Dr. Mary Amoji, a general surgeon, a breast surgeon, minimal invasive robotic surgeon as well. I've been here in the Dallas area for the past over 10 years. I have my own private practice. Um, we both went to school together at undergrad, got our bachelor's degree in medical lab sciences. I went on to go to medical school at UT Southwestern and did my surgical training at UTMB in Galveston. Came back, started my practice here in Dallas, and I've been in private practice for over 10 years.
That is wonderful. Thank you, Dr. Aji. We are happy to have such an intelligent, well-versed doctor with us here today. So, Dr. Aji, please, we're going to start, as you already know, we're going to be talking about breast cancer. Please, would you mind telling us a little bit about breast cancer screening?
Well, awesome. So, this is a good topic for this time of the month and a serious topic, but one that sometimes is ignored in our community as well. So, breast cancer, I mean, everybody knows that what cancer is essentially where it starts at a molecular level and alterations and things at the cell level that happens and create a situation where cells won't stop growing is essentially immortal. And so it is most frequently life-threatening cancer diagnosed in women worldwide, not just in the U.S. And it's one of the leading cause of of cancer death in women. So it's important to screen for breast cancer. And the way we do that is to recommend mammograms. Screening mammograms starting at age 40 is the right thing to do. Some will say, because again, different cancer society will recommend not exactly the same thing, but at 40, the general consensus is that at 40, every woman should have the opportunity to get a breast mammogram, a screening breast mammogram. And you may be in the boat of those that get it yearly, or you may be in the boat that get it every other year. But at 40, you should start breast cancer screening. Now, that's for the general population. If you are someone who has a family history of breast cancer, especially in your first degree relative, and first degree meaning your sister, your mother, your immediate family member, then usually it's advised that you start any screening about 10 years younger than the person was diagnosed, or whatever the general population is advised to do. So whichever comes first. So if, for example, your family member was diagnosed with breast cancer at 40, then your screening doesn't start at 40. Your screening starts at 30. So breast cancer screening involves, the mammogram like we talked about, and then it also involves being aware of your breast. So it's no longer recommended. Breast self-exam is no longer recommended as a screening tool for women. It doesn't mean that you don't check your breast. Instead, what we're pushing more of is what's considered breast awareness, meaning you are aware of your breast, you know what your breast looks like, what it feels like. That way, if there were to be any changes, you know that, and then you follow up with your doctor and make sure that's taken care of.
Thank you, Dr. Aji. That is a good encouragement for all of us. If you have been putting off your mammogram, make an appointment today. Go get your breast checked. And then if anything is found, anything suspicious, they will take it further from there. So if you have been putting off your mammogram, please get it done today, especially if you're 40 years or older, or if you have a family history of breast cancer. Let's say your mom had it, like Dr. Oji said. Now, what year did your mom have it? Make sure you get your breast checked even before that year. Thank you so much, Dr. Oji. Now, I think our audience would like to know you have performed many breast surgery. So, from a surgeon standpoint, what should they expect? Like everybody that have breast cancer diagnosed, would they need surgery, or what is expected in terms of surgery where breast cancer is concerned?
Okay. So I'm going to go a step further and then kind of bring it back and then bring us back this way. So, we started with the screening. So you want to screen for breast cancer. And there may be people in the audience who may know someone that maybe, sitting somewhere today and going, well, I already feel this thing on my breast. What should I do? So when you feel, or you already feel like something's wrong with your breast, or something's different, maybe not wrong is the word, but something's different, because that's the whole purpose of breast awareness. So if you feel like something is different, you want to follow up, and you haven't had a mammogram and you're of age to have a mammogram, you should first of all get that mammogram. But if there is definitely a mass, a lump there, that's not the time to get a screening mammogram. So that's very important for us to, say this. If you find screening is for those that have nothing going on. That's why the word is screening. So screening meaning there's nothing wrong with you. You don't feel anything with your breast. You're just going to do your screening test. But if you do feel a lump, if you feel a nodule, if you feel something, then what you need is now considered a diagnostic mammogram. You need to see your primary care doctor, or see a breast surgeon, or see a breast doctor, whoever. But what you would need going forward from that will be a diagnostic mammogram. And so once you get the diagnostic mammogram, usually most diagnostic mammogram will go along with a breast ultrasound, so a sonogram of that breast itself. And that will give us the characteristics of whatever that mass is, lump, nodule is, and that will be able to put that nodule more in perspective. For example, not all lumps are going to be cancer, right? Some lumps are going to be completely benign, but that's where the diagnostic mammogram and the ultrasound comes in. Or how about if maybe they saw something on your screening that they were worried about, and they said, okay, we got to come back, we're going to go do a more emphasized look at that particular area and do a diagnostic mammogram. Then they may call you and say, okay, on further evaluation, it was nothing. So not every callback means that there's something bad. It just means they don't have a prior on you and they need to take a second look in that particular area. And so once we do find the mass, you want to get a diagnostic mammogram, an ultrasound, and based on the characteristics of that ultrasound, a biopsy will be recommended. So it's a series of steps. And that biopsy is not usually surgical, even though I do get a lot of patients sent right then and then as if we should go and openly cut on people. So we try as surgeons to have diagnosis before going into the operating room. So that means you're going to go to a radiologist and get a radiological biopsy, meaning they're going to, the same way they found the mass or whatever, they're going to, under ultrasound or under, mammographic, which we call stereotactic, they're going to do a natal biopsy. So less invasive, not cutting, not going to sleep. They numb you up, they go into that nodule, they get a bite of it, like I like to say. And then they send that to pathology. And then pathology will be able to say, yes, based on, that this is cancer. And now when you now have that diagnosis, that's when you're sent to the surgeon, okay? Now, depending on what kind of cancer, what stage, which will base it on size of your tumor and all the other things going on. Do you have lymph nodes in your axilla and all those places? You may actually see an oncologist first before you see a surgeon, or at the same time. So meaning you may come see a surgeon. We talk about what needs to happen. But if you are at a higher stage of diagnosis, you may opt to go oncological first, get what we call neoadjuvant chemotherapy or some kind of therapy started ahead of time to shrink the tumor before you then proceed to surgery. If you're the early stage type person, stage 1, yes, then you may proceed to surgery. And that's when we now talk about the different types of surgery, the options for you, right? You want me to go into that? The options for surgery will be a partial mastectomy or full mastectomy. It's always an option, meaning you can take out the tumor and still have your breast, most of your breast intact. Or depending on the type of tumor, you may also choose to say, I want the whole breast removed. And that is all individualized based on what kind of tumor you have, the size of your tumor, what age you are, right? Because if you're a young 20-something-year-old woman being diagnosed with cancer, what you may do may be completely different from what someone who's in their 80s would do having been diagnosed with cancer, surgical-wise.
Thank you, Dr. Orji. So I get that what you're saying is depending on a whole bunch of factors, we determine if the person will need surgery or not, correct?
Most will need surgery. When they will need the surgery is now what will be determined. Some may need to get chemotherapy before surgery, and some may need to get it after surgery. Yes. And what kind of surgery will be determined on what it is that they have. Yeah.
Thank you, Dr. Orji, for that elaborate answer. Well, so what would women in their childbearing years expect? Like, will you be able to still breastfeed if you have children after breast cancer? Or would you like to tell us a little more about that?
So I think in general, yes, that is one option there. But most people, when diagnosed with breast cancer, I think the biggest thing, and I'll come back to that as well in terms of breastfeeding, there's so many things that goes along with treatment of breast cancer. So we just talked about potentially surgical, which is the mastectomy, partial or partial mastectomy or full mastectomy. There's also the chemotherapy and the immunotherapy as well, and other types of inhibitors, whether it's selective or non-selective inhibitors, hormonal blockers that are used. And then there is also radiation. Okay, so if you are saving your breast, because obviously if we're talking about breastfeeding, you're opting to have a partial and still have your breast. So the good news is we have two of those things. So for the most part, the other one is still available. So if someone chooses to breastfeed, can they still do that? Yes. I don't find that most people really kind of want to. But yes, they can, but not necessarily in the other breast if it's been radiated per se. Nothing is going to be the same. So that's just being honest in terms of from that standpoint. Yes.
So the answer will be yes.
Yes, they can, because there's two.
After breast.
There's two breasts. So the
Okay.
one that you get radiation on, you may not want to because it may not function like the other one. But what I do find is that for breast cancer, is that if you are of childbearing age, then one of the most important thing is not just even breastfeeding, it's being able to secure your fertility. Because if it's somebody that requires chemotherapy, well, chemotherapy can be destructive to all those things. So it's important if it's someone that really that still looking forward to having kids, it's important to talk to your doctor about those options to know what is available to you, and not just assume that if you go through chemotherapy, especially, that fertility is still maintained at the end. So we need to be careful in terms of, it's important whenever we as physicians, as healthcare providers, are talking to patients that are still of childbearing age to ask that. Don't assume, but ask, do you still want to have kids? Or even if they don't have any kids, do they want to have kids in the future? And therefore, they may choose to freeze some eggs, and just know what their options are in terms of their fertility.